people coming and going. Daniel joined her, where's Daniel, this year, and that just made it 2 tons of trouble with both of them there. But we're in good hands with Daniel. But I want to really thank Lee for taking the time out of her job. She recently retired and she's now teaching. She's teaching full-time, working full-time, and truly paying attention to this work. Line editing things, driving poor Nina crazy with spell check and everything like that. So she's been terrific, and I'm going to really miss her. You're part of a class of chairs that, in my experience of being here, truly are outstanding. So don't be a stranger, but don't worry, I'm not going to call you at 8 in the morning anymore. So in honor of your nitpicking, line editing, spell checking, it's with deepest appreciation we thank you for being on the council.
You can always send me new copies later.
Thank you. Keith. This is Reverend Keith Holder, and Keith has been involved in our consumer committee work. Keith is a Housing Works protege, if you will. And his work with the council has always been a fresh and invigorating voice in this committee work. His time on the council is appreciated. His work at Housing Work has consumed him, like most of you, and it's just really been an honor to have you on the council, and I really thank you for your service.
Thank you so much.
So it's with deepest appreciation that we honor you for your hard work and dedication from members of the Planning Council.
Thank you.
All right, Keith, thank you. Okay.
Deborah.
Where's Deborah?
Down because it's freeway.
Oh, there you are. Okay. Well, Deborah, what can I say? Now, Deborah was a risk. When she came in for the interview, she had just completed a film, and you know, we don't have a lot of filmmakers on the Planning Council.
What's the name of my film? Positive Attitude.
But exactly. She has been really great because she brings to the council a perspective of living with HIV, of people's lives of being HIV positive, that those of us who provide client services cannot experience. And she's never been shy about expressing her opinions, even though they may be contrary to the prevailing opinion. And that's what a democracy is about. And I really appreciate the fact that you've consistently shown up and let your voice be heard, whether we agree or don't agree. And you even come up from South Beach.
That's right.
Now, who would want to leave there in the winter to come up here and go to a committee meeting? But she did. And your time here has been well spent, and really thank you for your work.
Thank you for letting me say that.
Here you go.
Thank you.
In honor of your hard work and dedication, you as a member of the Planning Council, we show you our deepest appreciation.
Thank you, Jess.
Thank you.
May I just say a couple words of thanks to all of the members who are cycling off the Planning Council. I really appreciate your time and dedication to this very labor-intensive and passionate process. It's unique in public health that we have this level of advocacy and input and responsibility for public health resources, and it's an honor to be a part of this with all of you. It's you talk to other people in maternal child health or diabetes, and this level of input is unheard of in other areas, and we should be very proud of that legacy. But I specifically want to thank Robert for his time, and actually as a role sort of for a mentor for me, that I really have appreciated that since I came to New York 4 years ago. You've really stepped up and been there for me. I appreciate that. Nancy and IOC, we've had some really passionate arguments, and you've always been a person who keeps your feet on the ground and sort of has a steady hand and really keeping an eye on the prize, which is improving the lives of people with HIV, and I really appreciate that. Dr. Hildebrand, I really appreciate your dedication to the Needs Assessment Committee and the fact that we created a needs assessment. It's incredible, so exciting. And I also really want to thank all the consumers. Felicia, Victor, where's Victor? He's not here. Kareem, Gregory, Sandy, Reverend Holder, Mu Ying, Deborah, who's been coming from South Beach, and I just love that you always speak your mind. It's been a joy to serve with you, and Pastor Payne. So thank you all so much. It's been a pleasure. I always, during the summer months when we have the break, I always feel a little sad that we don't have the Planning Council. I get so excited when October comes. You might not know that from some of my comments, but I really do enjoy this work, and I thank you.
Okay, now it's time to roll up your sleeves. Got to vote on a bunch of stuff here. So let's start with the minutes. David, and then Daryl, you want to go through this like ream of paper here in this folder for us?
Sure. Okay. All right. The minutes were sent at least a week in advance. Didn't get any feedback, any changes, corrections. If not, the minutes stand. Thank you.
Okay, so in our packets today, after the minutes, we've got the two candidate statements for the community co-chair. The first one is from David Martin. The second is from Lindell Urbano. After which appear the Mental Health Services Directive and the Home and Community-Based Health Services Directive, which we will be voting on today. Followed by the PSRA packet that is clipped together that includes the FY13 carryover plan, the ranking tool, and the base and MAI spending plans, as well as the Tri-County budget. The next set of documents is from the Finance Committee. There's the closeout end-of-year expense report for the Planning Council budget, the year 23 fourth quarter closeout for base and MAI, and then the very colorful chart on the administrative mechanism, which we will be voting on today. Finally, we've got the policy hot topics presentation, and then the grantee report that has some articles on Dr. Dimitri Daskalakis, who is our Assistant Commissioner for the Bureau of HIV/AIDS Prevention and Control. I've also included two health advisories from New York, from the Department of Health, one on meningococcal disease. That's notable because the first case was reported in late June, and this is the first case since February 2013. And then the next advisory, which addresses an increase in synthetic cannabinoid-related adverse events and ED visits. There is the Dear Colleague letter from Dan O'Connell from the AIDS Institute outlining their approach to end AIDS, followed by two articles from the New York Times and from Treatment Action Group regarding the New York State Plan. We've included an invitation from ACREA and Amedicare for the White House ONAP, the Office of National AIDS Policy listening sessions, followed by the actual invitation and description. You need to fill out the RSVP form, send it in order to get a ticket to go to either or both the August 7th and August 8th sessions. The August 7th-ish session will be in Manhattan and will address issues in Manhattan and the Bronx. And the August 8th session, which is on Friday, will be at Brooklyn Law School, focusing on issues in Brooklyn, Staten Island, and Queens. And finally, we ask that you complete the Planning Council meeting survey, which we've included in your packets, and give them to any of the staff members here so that we can look at how we've done this year. And that's it. Thank you.
Thank you, Daryl. Thank you, David. Lindella's is running late, and I think that in all due fairness, if David doesn't mind, we can just go into the Integration and Care Committee report and then conduct the election after that. That's good. We also have a period of public comment. Are there members in the audience that would like to take this opportunity to speak? Yes.
There's a mic in the back.
Hi, my name is Stephanie Howes, and I'm from AmitaCare, and
I'm Joel Lenovitz from Korea.
And we're very, very excited. I just heard that you have in your packet information on the ONAP forum that's going to happen on August 7th and 8th. And we have extra handouts for you just in case you want to bring it to your friends, family, community, clients, patients, because we really want to pack the house because we're New York and they've been all over the country and then they're coming here. And so we have to turn up, as the young people would say, and turn out to make sure that our voices are heard and they understand what's happening with AIDS and HIV in New York City. So we're going to just have some handouts. You can tell me what's appropriate or not. I'll have the cards available to you, and we have a couple of posters too if you want to post them. And so if you need extras, just please let us know. We'll put them on the side, and we're just very excited to present to you to let you know about this forum.
So can you just share with the council the registration process, or how do we RSVP, and what if you want to deliver a statement? How's that all work?
Well, on your card, you'll see that there's actually two ways that you can RSVP. We've put a RSVP line and email here on the card that you can come in, and then the White House also has a link that's in your packet that you can fill out, and then you will be on the RSVP list. And then the day of the forum, we're going to have an entire section after some brief presentations for public comment. And so we will be soliciting individuals to step to the mic and speak for 2 to 3 minutes on whatever topic they want to speak on in regards to HIV/AIDS care in New York City. So that's the format, and we're very, very excited, and we want people living with HIV and AIDS to come out and speak, as well as service providers and also folks in government. So feel free to speak to us after, and I will also leave cards on the side if there are no other questions.
Great. Thank you.
Thank you.
Okay, so we're going to go into the Integration and Care Committee presentation. And as I said previously in saying farewell to Nancy, her work's not yet done. She's got to bring us up to speed on mental health and community-based health services. These are two new service directives. We've reworked the mental health service directive, which will eventually lead to an RFP, and the same with home and community-based health services. Currently, we fund mental health services at $5.3 million and home and community-based services at $1.2 million. We learned a lot in the process, and I won't take up any more of Nancy's time in explaining that, other than just say that it was very educational, and there's just a lot going on in both of these service categories that, took us some time to work through until we were clear about how we wanted to fund those services. So Nancy?
Yeah, mental health actually took a little bit longer than the home health directive. We met twice a month. starting in January. So we met more than other committees did, but it was needed. We reviewed current Ryan White funded mental health services in New York City. We reviewed a survey of current providers. We hosted a question and answer with current providers. We discussed mental health services and managing non-billable work. We conducted a literature review of recent studies of mental health services for people living with HIV and AIDS. We reviewed mental health services provided to HASA clients by Part A funded providers. We reviewed New York State funded mental health services provided at syringe exchange programs. We reviewed geo-mapping of mental health service in New York City, and we constructed and improved a new mental health service directive. All right, the goals. To provide treatment and care to people living with HIV/AIDS with mental illness with or without substance use disorders, to improve quality of life and mental health functioning, to overcome barriers to mental health care, to facilitate ongoing involvement in biopsychosocial care and treatment, including adherence to ART and/or psychotropic meds, and also to reduce the use of emergency care. The objectives: to increase proportion of newly diagnosed individuals who enter primary care within 3 months of diagnosis, increase retention in HIV care and treatment, increase proportion of clients with optimal level of ART adherence, increase viral suppression, improve immunological health, decrease reliance on acute care, reduce socio-demographic differences in delayed diagnosis of HIV, reduce socio-demographic differences in prompt linkage to HIV care after diagnosis, reduce socio-demographic differences in retention in primary medical care, and reduce socio-demographic differences in viral suppression. The philosophy of this directive is it's client-centered, non-judgmental, guided by harm reduction principles, trauma-informed, culturally appropriate, and tailored to population served. Who is this population? They're individuals with diagnosed mental illness or in need of mental health services, persons with co-occurring mental health, substance use, and other medical conditions, individuals with physical, behavioral, psychosocial, or sensory impairments that may or may not limit them from presenting to an office location. They're chronically homeless and unstably housed people living with HIV/AIDS. They're homebound clients, and they're gay, bisexual, other SMM, lesbian, transgender men and transgender women, and immigrants. The required components is a referral to medical care, SCM, housing, substance use treatment, independent living skills, food and nutrition, and legal services. Individual and/or group treatment adherence counseling, including discussion about primary care status measures, appointment adherence, ART, and psychotropics adherence, and coordination with clients' providers. There's going to be a mental health intake, assessment, diagnosis, and treatment, crisis intervention, individual and/or couple, family, and/or group mental health counseling services provided. Optional components: psychiatric evaluations and follow-up visits, psychiatric reevaluation, psychotropic medication monitoring and management, and linkage with inpatient psychiatric care when indicated. Individual, group, and family services for clients with a history of or currently using alcohol or other drugs. Client engagement activities, scheduling appointments and coordinating services. Outreach for client re-engagement to monitor, schedule appointments, and follow up on missed appointments. wellness individual or support groups to educate and monitor clients on key issues related to the client's current mental health needs and potential barriers to mental health treatment. And interpersonal violence assessment and intervention. Special considerations will be given to accompaniment services as appropriate to external agencies and within the mental health programs facility. In other words, agencies that can. Host-based services for clinical purposes, including services listed above as appropriate and necessary. Next slide, please. Who's eligible? Clients, well, individual and family units with one or more HIV-positive persons and in which the HIV-positive person has a DSM-5 diagnosis. Active substance use does not preclude eligibility for and maintenance and services. Household income less than 435% of federal poverty level, and clients living within the New York EMA area. Agency eligibility is a licensed Article 31 or Article 28 mental health providers currently certified to deliver outpatient mental health services. CBOs with an MOU with an Article 31 provider who has added the CBO site to its licensure. Organizations should have multidisciplinary mental health programs including counseling, psychiatric care and/or pharmacological management, and alcohol and substance use services. The agency should use multiple evidence-based therapeutic modalities and/or best practices, including harm reduction approach. They should have experience with HIV-positive persons and active substance users. They should have experience with persons who are out of care or sporadically in care, transitioning from institutional care or needing self-management support. They must be co-located or have linkages with programs providing medical and psychosocial support services, Medicaid, Medicare, and NYS, New York State Health Insurance Exchange Systems, and health homes. Must ensure that staff have HIV knowledge, training, cultural sensitivity, and must be able to provide services in languages of populations served. Must be accessible to clients from throughout the New York EMA area. Next steps. This was already approved by the PSRA committee on July 21st. It was then approved by the executive committee on July 24th, 2014, and it's being reviewed by the full planning council today, and if approved, will then be referred to the grantee for development into an RFP. Council will be notified by the grantee when the RFP is released and is informed when providers are identified. Thank you.
Okay, it's your job to vote on this. And as Nancy has shared with you the process of coming out of the Integration of Care Committee, being presented to the Priority Setting Committee, which approved the service directive, being presented to the Executive Committee, which approved the service directive. Now it's your turn. If you have any questions about the service directive, this is your opportunity to ask them before we move to a vote. David.
I just want to assure that the population that's mentioned in the slide presentation finds its way to the actual program directive, because that line is still not in the program directive that we agreed on in executive committee.
Okay, well, let's be clear. Where in the directive and how would you like the sentence worded?
It was supposed to be the third bullet.
It's listed in this slide.
Are you looking at the PowerPoint, or are you looking at it?
I looked at the PowerPoint because that's where the line exists, but it only exists in the PowerPoint and not in this program directive. And I think we said the third bullet under program directive and service model.
Jen, let me...
it's right there.
Yeah, I think if you look at the bottom left-hand corner showing the date and the time, the service directive that includes David's recommendations was, what is that, 5:53 p.m.? Nina?
The one I have is 5:31 p.m.
5:31 p.m. So I think that perhaps in your packets it appears as 12:20?
12:20, right.
Okay, so that is the discrepancy. There were several versions that were circulated, so.
But rest assured, the third bullet.
Use your microphone, please.
Okay. Just to alleviate any anxiety, in the Mental Health Services Directive, if you look at the third column under Program Directive and Service Model, there is some material in bold about services should be client-centered and non-judgmental, etc. Then there is a whole procession of bullets, and the third bullet reads as follows: individuals with physical, behavioral, psychosocial, or sensory impairments that may or may not limit them from presenting to an office location.
So that's in your...
The version that Nina is speaking of is at 5:31, the printed version. The version that might appear in your packets is at 12:20, and her version contains the corrected language.
I think this was the version that we had at the executive committee that then we worked off of and changed, and then Nina has the one that was actually changed. Yeah.
Rest assured, David, it will be in there.
Okay, I just got it.
Nope. Hey, you caught it. That's a good thing. Okay, a little technical glitch, but the language that David's referring to is in a newer version that some of you have and some others of us do not have. And as Nina has explained, it will be in the service directive itself. Other questions, Saul?
No, I just want to make everybody aware, it's on the site. When, I think, Juan sent us a preview of all the information in the packet, and so you can, it was there, because I printed it out and that correction was
The
there.
version that was sent out by email was the correct version. We just, the Xerox was an earlier version. There was so many versions, somebody got confused, that's all.
But it's available.
Good thing it's not brain surgery. Okay, it's fixed. Do I hear a motion to accept the service? Oh, I'm sorry, Dova?
Under client eligibility, my understanding is that these services are available for people who either don't have access or have, for whatever reason, have not accessed services that might otherwise be available to them. So I just wanted some clarity on that, please.
Yeah.
That question?
There's no mention under client eligibility in terms of people who might have access to other services, mental health services under Medicaid or under other, auspices. So I just wanted to know whether this is in fact open to everyone who qualifies, as the more detailed mental health services directive says, under Ryan White eligibility, or for, that's my question, whether it's solely Ryan White eligibility below 430% of FPL as opposed to people who don't have access readily to other services.
Did you want to answer that, or do? Okay.
So you're right, Ryan White has a payment of last resort requirement, but there are gaps in the service system that we pay for that aren't paid for by Medicaid or private insurance. So those clients who may be covered by Medicaid but may need engagement in mental health services, for instance, or they may need services in the home, are two types of services that they may be eligible for. But the full package of services in the directive would be available to people who have no other payer for services.
Thank you.
Other questions? Kimberly?
Hi. This seems like an incredible amount of work, so thank you. But I haven't been in the weeds at all with this, and I just wonder if there's somebody who could sort of summarize any sort of salient differences from the last service directive regarding mental health, or any hot topics, as a policy committee folks like to say.
Nina?
Kimberly, this service directive does not really differ in a major way from how mental health services are currently offered. It is primarily a tweaking and adjusting, taking into account more recent articles in the literature, but it is not a fundamental transformation of the offering of Ryan White mental health services.
That may not be the answer you wanted to hear, but it's true. You know, after we went through all of this process and looked at behavioral health homes and, you know, what you get from Medicaid and all the other places where you can seek out mental health services, you know, we were really looking at filling the gaps. And that's the salvation of this particular funded service category. So there were smaller tweaks in that, and there was some debate about that and how we would manage that. But it became clear to us that this is a gap filler, and that there are a number of other places people can seek mental health services, but there are some places where people, undocumented individuals or others that don't have access to Medicaid or Medicare, can't get them any other place. Sharon?
I also think that it's on the fourth page, the fifth page, the engagement activities to engage the client in the preparation for accessing mental health services and the more strong connection between the delivery of mental health services and the ongoing connection to medical care and treatment adherence support, outreach for folks who have either stopped taking their psych meds or their HIV meds. So these, I think, are also sort of newer, and they update the category, make it more relevant to the lives of the people that they're serving, and are still within the spirit of both the mental health licensed delivery service as well as the broader goals of connection to medical care and treatment adherence. So those dotted lines were more firmly drawn in this than in the prior, is my understanding from all the presentations.
You know, you've raised a very good question, and in our next presentation on home-based care, we do have a slide on what's new. What's new in this? And we didn't do that in this presentation, but I think it should be a component of all of our presentations, so that then your question could be readily answered.
Good point.
Are there other questions?
Just comment. So essentially we're rebidding just because it's time to rebid, and not because we did anything structurally transformational or completely different?
Well, sort of yes and no. I mean, we recognize that the environment around us is changing dramatically, and we wanted to make sure that the services that we were delivering were appropriately responding to that. And in our discovery process, we felt, for the most part, they were. But there were pieces, as Sharon has mentioned and others have mentioned, that we wanted to see embedded in a new service directive. Now, the process of Graham can speak to the process of RFPing and how these service directives come up within the council in a timely way. But I can't remember the last time this particular service directive was bid, but it hasn't been that long.
2007. We specifically wanted to work on this service directive with the Planning Council because we knew that the health and recovery plans through Medicaid were going to be rolled out in about a year. And so we wanted to be sure that we reviewed our constellation of services to be sort of think about how do we fill the gap, knowing that that will sort of come into existence. So we had someone from the New York State present on those and sort of realize that it would be a subpopulation of a subpopulation of a subpopulation that would be eligible for the most intensive services in those Medicaid-covered health and recovery plans. So we went forward and created a directive that would continue to honor payment of last resort, but also address more intensive home and advocacy and accompaniment services to really address the unmet need, mental health need that we see in our population, so that we can further engage people with HIV in mental health services.
So that's my point. So thank you, Graham. So there were some decisions made around some other service directives or service categories in the portfolio to hold or to postpone because of, precursor to HARPs and DSRIPs, health homes, to see how it all, shook out, and then to adapt the Ryan White system to that. So this is different. So we're getting out in front on the mental health directive, right? This is just about strategy right now. I'm not critiquing one way or the other, but I want, as I do my swan song right now, for people to understand what you're facing for next year, is that strategically, the entire portfolio needs to be looked at with all of these changes, right? So health homes, health and recovery plans, the HARPs, DSRIPs, whatever DSRIPs acronym is, payment system, whatever, and think about, is the strategy going to be preemptively look at it, which is a smart strategy, and try to fill in the gaps and figure out, how it's going to work together, and speak to all the experts, like as was done by your committee, which is the right thing to do, or strategically do you wait for the health reform changes in New York State to keep rolling like an endless tide, and then figure out how to adapt the service category? So we've done both in the last couple of years, and I would ask the grantee and the Planning Council office just to pay attention to that and how it shakes out and evaluate it, because we don't know I don't think we know what's better. What I do know is that there are unknowns with HARPs and with DSRIPs, and we just need to make sure that there's some kind of strategy for this very distinct slice of dollars that we're using to fill in the gaps and to leverage the system out. Because bottom line, these changes that are in this service directive, and it's an enormous amount of work that I applaud and bow down to, it could have been done through the grantee and Public Health Solutions making changes to the current contracts. That's why I'm going back to where I started, but it sounds like it was time to re-RFP 7 years, 9 years, whatever, 2005, 2007, whatever it was. But just understand what you're doing, because the changes that are being proposed could have been made contractually if it wasn't outside of the spirit or the original intent of the original service directive. I think it's great to do more escorts and accompaniment and more co-location. That's all, and home-based services, it's all good stuff. But just keep those things in mind strategically. Do we need to tweak a service directive? Or does it need to be looked at, revised completely? But if you're going to go through the process of revising a service directive, you might as well go, all out and figure out, like you've done with some other categories, with collapsing harm reduction related mental health services into supportive services. I think that's really great stuff. But it's just a point that I want to make as the veterans go into next year, and then you get an influx of new people, is just to think about it instead of just doing it one by one, because when you do it that way, sometimes you don't see how these things could be integrated more or connected more. So I hope you understand my point. But
Nancy?
Yeah, I just wanted to add, just to piggyback on what Robert said, I mean, in addition to this being a lot of work, which it was, it was very difficult because we don't know what the future holds. And so, we were able to get experts on it, but the bottom line was that they weren't very clear on what, what I mean? Right. So I suspect, yes, you're right, Robert, that they will be tweaked as it goes along, just to sort of accommodate what's down the pike, so to speak.
Any further discussion? All right.
Can I make a motion?
Yes.
To accept the Mental Health Service Directive as amended and tweaked, or what is it? As presented to the Planning Council.
Is there a second?
Second.
Is there further discussion? All right. The motion has been made and seconded, and the discussion is concluded. We'll move to a vote. All in favor? Opposed? All right. Thank you, Nancy. All right. Now we're moving on to home and community-based health services. This too was rigorous. This too, many people showed up. This too, we had a number of presentations. This too is being done in other places and paid for by other people. And this service directive hasn't been reworked for quite some time. So it was way overdue, and it gave us an opportunity to look at a very sliver of a population of people that we're able to reach through this particular funding, $1.2 million of services. Small number, around 400, depending on some of the services. But these are people that just can't get this service any other way. And we debated back and forth over a number of council sessions whether to continue to even fund this service category. And priority setting wasn't comfortable. Defunding it, send it to the committee to review and come back. And now it's here. So Nancy, you want to go through this?
I think Jan, Nancy's a little bit under the weather, so I had agreed to...
if not, I can do it, Nina.
I'm happy to.
Go ahead, Nina.
Okay. All right, so the creation of the Home and Community-Based Health Services Directive was considerably easier and less contentious than crafting a Mental Health Services Directive. We met a total of 5 times beginning in May. Of course, we reviewed current Part A funded mental health services. We discussed a glossary of home care terminology because there are a lot of terms in home care that people kind of blur together: homemaker, home aid, patient care assistant, and so on. And we needed to get straight, what was what. As usual, we had a Q&A session with current providers of home care services who joined us in a panel. We also discussed home care services with consumers. We reviewed Medicaid managed long-term care, and we crafted and approved a service directive in record time. So the goals are 2 here. Basically, the first is very familiar. We want comprehensive, coordinated home and community-based healthcare, support services. All of these should facilitate continued retention, engagement in care, and enhance the quality of life. And very importantly, we want to reduce the number and the length of time involved in hospitalizations, and of course, reduce the number of nursing home placements of people who are living with HIV. Next slide, please. Okay, so I'm going to skip over these objectives. These are taken from our comprehensive plan for HIV/AIDS services in the New York EMA that was delivered to HRSA several years ago. These are basically boilerplate within every one of our service directives, and they all refer to engagement in care, retention in care, improving immunological health, and reducing sociodemographic disparities, and I think we're all pretty familiar with them at this point, and we have a packed agenda today. Okay, so required components: HIV treatment education, assistance with staying with your meds, client engagement activities for scheduling appointments, coordinating services, maintaining your connection to primary care, and advocacy services to assist with navigation of home care resources and address any grievances that may come up regardless of who is paying for them. And I'm just going to dwell for a moment on that. We heard from consumers that if you are a patient receiving home care services, you may feel quite vulnerable. You're at home, you're possibly alone. If you make a complaint about the individual who is providing home care, you might start having items disappear from your apartment, who knows what. So we wanted to create the possibility of a person who could sort of moderate and modulate, deal with any such complaints that might arise, and that person would be empowered to deal with complaints regardless of who was paying for the service. Next slide, please. Great. So additional required components include outreach for re-engagement, psychiatric evaluation and visits, individual and family supportive counseling, substance use counseling, and homemaking and shore services, including provision of child care. Also included are home health and personal care services, skilled nursing, home intravenous and aerosolized drug therapy, provision of durable medical equipment, physical therapy, occupational therapy, speech therapy, independent living skills, nutritional counseling and emergency food provision, and respite for caregivers and childcare during appointments and hospitalizations. An optional component, and this is important here, is the use of a multidisciplinary team, including peer-delivered services. And again, the reason why we included this, although it is optional, is because of what we heard both from the peers who joined us and from the providers themselves. Often, if a patient is being discharged from the hospital and they start learning that a series of home care providers may be coming to their home, providing services, traipsing through their apartment, their initial reaction is, no, I don't want this. And they may, for example, give the wrong address. So the visiting nurse shows up, or the social worker shows up, or the homemaker shows up, and lo and behold, they were given, incorrect information, and they can't even find the patient. So the hope is that by leaving space for the possibility of a peer could help the patient sort of absorb and assimilate the idea that there will be this progression of people coming through your home, but that in the long run, the goal is actually to enhance your life, to make things better for you, and will reduce the potential tendency of the patient to sort of back away and back off. Next slide, please. So who is eligible to receive these services? Most of this is pretty familiar, but I will call your attention to the last bullet. First, though, it is individual and families in which one or more of the members of the unit is HIV positive. You can be an active substance user and still receive services. The household income must be below 435% of the federal poverty level. Of course, the client has to reside within the New York EMA, and the clients with physical, behavioral, psychosocial, or sensory impairments limiting them from presenting to an office location. And this was a point that David brought up a little while ago regarding mental health services. It came to our attention, to the Integration of Care Committee's attention, regarding home care first, even though this was our last service category of the year. And we felt, what we learned from the consumers was that if you, for example, are visually impaired, the person who is providing your home care needs to really be trained to work with that, because if you are visually impaired and the person providing the home care moves the chair and you try to sit down in the chair and the chair isn't there, you could have a pretty unpleasant situation on your hands. If it refers to psychological impairment, you may also have a patient who is afraid to leave the house to go receive their mental health services, and you need to have somebody at home who is sensitive to that, attuned to that, perceptive, and informed. So basically, we wanted to ensure that clients who have these various sensory or psychosocial impairments would be accommodated within this service directive. And as for agency eligibility, most of this is pretty familiar. Organizations, of course, have to be experienced working with PLWHAs, reaching out to and engaging them in care. They have to be co-located or have linkages with programs that offer medical and psychosocial support services, Medicare, Medicaid, New York State health insurance, exchange systems, and health homes. And they either have to be able to bill Medicaid for Medicaid billable home-based services or be in a contractual relationship with another agency that can bill Medicaid. Next slide.
That is next one.
Then this version, okay, is not the final version. If you look in your packet, there are additional slides, including one. I hope the correct version was included in your packet. There is a slide that talks about the fact that this is not dissimilar from how services are currently provided, but that there are a few points. Okay, there we go. There are a few points worth noting. As I mentioned before, agencies that are funded under this service category can offer advocacy services to assist with navigating the home care system and dealing with any problems or complaints on the part of the recipient of services, regardless of who is paying for those services. The funded agencies can include peers if they wish to help patients adapt to service provision. We do address for the first time the issues of clients who have sensory impairments, and we do require co-location or linkages with programs providing New York State health insurance exchange systems and health homes. Next slides. Good. So this was reviewed and approved by the Priority Setting Committee. It was reviewed and approved by the Executive Committee 1 week ago today. It is, of course, being reviewed by the full Planning Council right now. If it is approved, it will go to the grantee for transformation into an RFP. And then the Planning Council will be informed by the grantee when the RFP is released into the community, and the Planning Council will also be informed when providers are identified to offer these services. And the final slide is just a very, very warm note of thanks to everybody involved. That includes the committee members and especially the co-chairs, Nancy and Christopher Joseph, who cannot join us today, but is also wonderfully helpful in pulling the service directives together. We were also joined by several other Planning Council members, Randall Bruce, Billy Fields, David Martin, as well by Public Health Solutions and the grantee staff and other members of the Planning Council staff. So a very warm note of thanks to everyone who was involved in undertaking the development of this service directive.
Daphne, can you just go back to...
Yes, so slide number 11.
Excuse me, you use the microphone, I hear you. Sorry. Yeah, 11.
Okay, so Daphne is asking me to talk about slide number 11, which refers to agency eligibility. And we want to, as we always try to issure that staff have HIV knowledge, training, and cultural sensitivity, and our language, can deliver services in the languages of the populations that are being served. Again, the agencies have to be able to provide services to clients who have these impairments, or whether they are physical, behavioral, psychosocial, or sensory, that may interfere with their getting to an office environment. And any individual agency does not have to be able on its own to serve clients from all 5 boroughs, but the funded agencies should be accessible to clients who come from throughout the New York eligible metropolitan area.
Anina.
Sorry, I think Dova was...
Well, you finished?
I'm finished, yes.
Oh, no, I wanted to know about slide 5, under agency services. My concern is, what is the authority of the advocacy services? What authority does this person have?
So the role of the advocate is to, as it says here, to assist with navigation of home care resources and address any grievances that may arise regarding home care regardless of payer. That will be fleshed out a bit more, I think, when this is transformed into an RFP. It may prove to be a challenging role because if, say your home, the part of the problem is Medicaid-funded home health services, the Medicaid-funded provider may not particularly want to hear from a Ryan White paid navigator. But basically, overall, we can describe it broadly as somebody who has kind of a mediation role, can kind of address the problems, bring them to the fore, but in a non-threatening manner, and the creation of that position is intended to make the patient feel, as I was saying, less vulnerable, less isolated, less, oh my God, if I say something, they may start, this home health aide may start taking my silverware or my jewelry or whatever. So we wanted to have a resource to whom the patient could turn, because we learned during the course of the committee meetings that the visiting nurse service may come only once every 3 or 4 months, and a lot of unhappiness and a lot of negativity can fester during that interval until the next scheduled visit. So we want to have somebody who could kind of address and ameliorate any issues.
Thank you.
Sure. Dova.
I have 2 quick questions. One is, what is a psychosocial impairment? And the second question is, how do we differentiate between the mental health services that are being delivered or required under this almost RFP and those that we just discussed under the previous one?
Excuse me. So wait, I'm sorry. What was the first question again? Was
what's a psychosocial impairment?
So a psychosocial impairment would, for example, be a patient who would receive services at home because they have agoraphobia. They are afraid to leave the house to go to the psychologist's or social workers or psychiatrist's office. So those services can be provided to them in the home environment. And Graham, I think, can tell you as a former provider that he has encountered precisely that situation. Graham?
I would actually just suggest that we may want to delete psychosocial impairment, since it's not a term of art, and what you're describing is a behavioral or psychiatric impairment due to bona fide mental illness. Mm-hmm.
Okay, let me...
What about my second question about the seeming duplication of services, home-based mental health services, which are also being provided potentially in the other RFP that we just discussed?
There is indeed some overlap, but if you look at home and community-based services, home and community-based services is a very, very broad range. And if you look at what is currently provided, it includes, pantry bags. There is a very, very, very large range of what is potentially offered under this service category, whereas mental health services is really specifically mental health. Home care is, it's pantry bags, it's all sorts of other services as well.
Right, so why require psychiatric evaluations to be done under this RFP as opposed to bringing them in under the other one?
It's not required that everyone have a psychiatric evaluation. It's required that that service be included in the family of services for that contractor.
If you look at the bottom of your service directive for home and community-based services, we are, as with all HRSA service categories, we are limited by what HRSA allows us to provide. And if you look at the first footnote, under home and community-based services, it says allowable services include durable medical equipment, home health aid and personal care services, day treatment or other partial hospitalization services, home intravenous and aerosolized drug therapy, including prescription drugs administered as part of such therapy, routine diagnostic testing, appropriate mental health, developmental, and rehabilitation services.
I think part of the point that you're bringing up is that this service is provided elsewhere, and that happens in a variety of different places throughout the portfolio. The piece that's unique about this, different contractors have an ability, or services have an ability to reach different clients. So with this constellation of services, we're hoping that we can reach more of the homebound clients than with the mental health services, which are more embedded in the mental health service environment. So it's not a perfect answer, but it's an answer.
Bettina has her hands up. We should let Bettina.
I just want, this is Daphne. I want to say that the question that you've asked, we really discussed it in this committee. The same type of questions went over back and forth with each other, if you remember. I wish I brought my notes, but we thoroughly went, the same questions came up that you're asking, even in terms of social, using the terminology psychosocial versus psychiatric. And I can't remember what the reason is, but we went through this like a fine tooth comb. I mean, we had tons and tons of people there, back and forth for 2 hours. So if it sounds like no one asked, we asked all these questions, and I'm just sorry that I can't come off right now remembering the exact rationale, but we did go through it. Maybe Nancy can help out.
Thank you. So I'm going to apologize. I was not there when this was, but I think there, I'm not sure exactly what, I'm stuck, actually. You know, when we were, it differs in the sense that I think that this is a much more intensive sort of directive as far as home health visits and home, what's being provided in the home, as Nina mentioned. As far as home visits in the mental health directive, that's more time limited, and I think really it's for patients that fell out of care psychiatrically and actually are unable to leave their home. And so it was something comparable to, I guess, what an ACT team would do, where they would go out and visit the patient with the goal being that eventually the patient would then get into care. So it's more, it was more of a time limited. Bettina, you have your hand up, and I know you're going to rescue me. But I don't know if that sort of, Bettina?
I'll start with the home care. Home care is typically the type, or the home-based services are typically the services that in a medical facility would be called the home care services. And it has a number of elements that can include mental health services, but the crux of those services that differs from a mental health category is that that's a service that provides custodial care services. Mental health has nothing to do with that. So if someone needed a home attendant, this would be the category where they would get the services. If they also had a mental health issue, then they could get those services that are available also to be delivered in a home. Mental health is really mental health services traditionally delivered in the office. There is a service requirement that says if a person is homebound and does need the services in the home, they need to be provided in the home, but not necessarily by that mental health provider. It could be done by even referral of MOU with an organization that is able to provide it. But the driver of the services for that category is that someone has to have mental health need, where home-based services, they may not have a mental health need. They may be getting custodial services of a home care, whatever we call that title, a home care individual, and maybe they'll get something else. They may get the advocacy services or something else, but mental health needs to be available, but it is not a required service. And the venue for mental health services is traditionally the office, but may be delivered in the home, where the venue for the home-based services is always the home.
All right. So, are there any more questions or clarification needed on this service directive? Any other discussion? And can we have a motion from the floor to vote the service directive up or down?
Yes, I'd like to make a motion to accept the home-based, the Home and Community-Based Health Services Directive as presented to the full Planning Council.
We have a second? Sharon? We have a second. So, we're ready to vote? Do I have to open up for discussion again? That's it. Okay. Is there any further discussion? No? Okay, so let's vote. All in favor, please raise your hands. Thank you. All opposed? Passes unanimously. Thank you. And thank you for the great work.
Thank you, Nancy, and thank you, Christopher, who's not here.
Thank you, Nina.
All right, let's move into, back up a little bit, and conduct our election. And this is a formal process, and so I'm going to be reading from a script here. The next item on the agenda is the election of the Planning Council Community Co-Chair. According to Planning Council bylaws, Article 5, Officers, Section 1, Procedures for Election of Officers. The Community Co-Chair shall be a Planning Council member who is not a representative of either city or state government and shall be elected by the membership of the Planning Council. The election shall take place no more than 90 days before the end of the Planning Council session. The Community Co-Chair shall work with the Governmental Co-Chair in the preparation of agendas for the Planning Council and the Executive Committee meetings, and co-facilitate meetings of the Planning Council and the Executive Committee. The Community Co-Chair shall serve as the principal liaison to community-based organizations and the affected community. The Community Co-Chair shall meet regularly with the Governmental Co-Chair and the Planning Council support staff and perform the duties of the Governmental Co-Chair in the Governmental Co-Chair's absence. A nominating form was distributed to the Planning Council members, and 2 nominations have been received. According to our parliamentarian, Joan Corbisero, the method of voting would normally be by voice vote. However, if the Assembly, you all, approve, the election can be written by a written ballot. So, would you prefer a voice vote or written vote?
I propose a written vote.
Is there consensus on a written vote? Okay, all those in favor of a written vote? Great. Okay. All those opposed, sorry.
I want to pose for one last time. Thank you.
Oh, wow. Okay. So I'm still reading from the script here. So without objection, well, there was an objection, but without a majority of objections, the election will be conducted by a written ballot. Okay, now we have to appoint tellers. Okay, so the method of voting is by ballot. We need to appoint tellers. So David Klotz will be a teller, Darrell Wong will be a teller, and the chair of the Rules of Membership Committee, Felicia Carroll, in her last duty, will be a teller. And they will distribute to you all and collect the ballots and tally the vote. Okay. Where do the people have an opportunity to talk now? Oh, I lost that page. The following candidates have been nominated for the office of Community Co-Chair. David Martin, who's currently serving as the co-chair of the Consumers Committee, and Lindell Urbano. David, would you like to make a candidate statement before the election? Thank you, David. Lindell, would you like to make a candidate statement before the election? Yes. Thank you, Lindell. Okay, are there any other nominations from the floor?
Let them make their candidate statements.
All right, I have to back up and subtract that sentence. All right, now you can make your statements. David.
Hello, everyone. Good afternoon, and thank you for the nomination and the opportunity to present myself as the next community co-chair. I came and there was a handout of my background, but I come to this forum from probably a non-traditional avenue. You saw that my background is mostly the arts. And as a consumer, I feel that it's very important for those of us who are struggling and have had some success with managing HIV be visible and vocal. And in the 27 years that I've been HIV positive, it hasn't all been easy. It's been a struggle at different points, but I think the most important part is there's been a transformation. And you have seen part of the transformation for me. When I was diagnosed, it was devastating. And at that point, I think from what I aspired to do, I became a shell of a human being and isolated. I think the work that I've had, and it speaks to one of my passions, is mental health. And I've initially got a mental health practitioner, a therapist. And I think that transformed my thought about myself and my diagnosis and wanting really to get back what I lost, which was a will to live. I think all of those persons who come to the table as consumers need to have their voice heard and give credence to. They are of value. And I think as we see and sit around this table, we see that I myself and several other consumers have added to this process. So I think the majority thought, I think, is that consumers do add something to this process. And I'd like to be that for you and this HIV Planning Council. I think this is a well-oiled machine. I think I had a comment. I said, HIV Planning Council does meetings right, because I've been in some really hectic meetings, and this is a very good forum for actually the process that we go through. One of the things that I think I'd like to bring to the table is that connection from my communications background, from my public speaking background, from the different aspects of my past, that I think reaching out to the community, I did community outreach prior to this in my previous field, but I think part of getting people on board and embracing consumers is to get out into the community and have those partnerships and collaborations. In essence, create a mega community of CBOs, of government, of private sector, and actually working together, because some people do these things better, and sometimes, could you imagine Disney coming to the table and doing something, or Tony Robbins in motivation and getting people, consumers, back on their feet? So I just want to reframe, not necessarily reframe, but rethink how we approach the work, and maybe think, I know we have professionals, I give credence to everyone's expertise here, but I also want everyone to not get comfortable in thinking a certain way and think outside the box and be conscientious of how we can do things differently. I thank you for the opportunity. Thank you, Planning Council staff. All of you have been really supportive and embraced me, and I appreciate it. Thank you.
Lindell?
Okay, I'm just going to read my statement. So I'm Lindell Urbano. I've been involved with the Planning Council for quite a while, so as a person who is personally affected by HIV and who has worked with the Planning Council for many years, I view the chance to run for community co-chair as a special opportunity. The position will present me with a unique opportunity to give back to a body that has played an integral role in ensuring that people I love, work with, and care deeply about maintain access to critical care and services when they need them most. I fully recognize that the position of community co-chair carries with it immense responsibility and requires humility balanced with strength. I am prepared to step up to the challenge of working with the Planning Council to balance the needs of people living with HIV and AIDS with the Council's role in ensuring that Ryan White funds get to those who need them in the most effective way. For the last 5 years, I have facilitated an advocacy group called the Ashton Center. Every week, over 30 people living with HIV meet to express the challenges they face and strategize to propose structural solutions. They hardly ever agree. I use my strong facilitation skills and knowledge of due process to get through an agenda while allowing everyone's voice and perspective to be heard in a mutually respectful environment. In conclusion, I have dedicated my adult life to working to improve access to public health. In fact, I have a long history of working with people living with HIV, and my years of personal and professional experience will give me important perspective in the role of community co-chair if you choose to elect me to that position. Thank you for considering me.
Thank you, Lindell. Thank you, David. Are there any other nominations from the floor? Speak now or forever hold your peace. Okay, there being no further nominations, the chair, me, declares the nominations closed. All right, what happens next? David Martin and Lindell Urbano have been nominated for the office of community co-chair. Please mark your ballots. We will continue with the meeting while the tellers tally the vote. All right? Oh, yeah. Okay, David just made a great suggestion. Alan and Kareem were not here when we gave out these plaques, so I wanted to acknowledge their presence and thank them for their service and read my notes here, if I can find them, about their service. So Alan Vergara. Alan, can you stand, please? Has been a great guy.
It's not a eulogy.
All right, he was appointed by Mayor Bloomberg in 2009. He has served 2 full terms and changed jobs about as many times. He's really been an intellectual force in our financial discussions and in our work on the priority setting and resource allocation committee. His attention to detail in Excel spreadsheets, which most people's eyes glaze over when they have to focus on them, has been wonderful. you've really brought some great challenges to our critical thinking about how we spend our money and how it's used and how we interpret the information and provide it to everybody else at this table. And it's been very, very useful, and I want to thank you for your service. So this plaque, and you missed this part, so I can read it. Okay, deepest appreciation to Alan Vergara in honor of your hard work and dedication as a member of the HIV Health and Human Service Council, Planning Council of New York, August 2014. Alan, thank you for your service.
I'll give it to
Kareem, can you stand up, please? This is Kareem Clemens, and I want to thank him for his time spent on the council. And Kareem came to us like very, very new to this whole situation, and he adapted well. He was appointed in 2009, and here he is still today, here. And he's been involved in the council through all those years. He's brought a youthful perspective, I guess I can say that given my advancing age, and it's been greatly appreciated. There have been moments in meetings where he just needed to say a few words that really kind of changed the way everybody in the room thought about what we were discussing. And it's that kind of bravery and standing up and giving life to your voice and how you feel and how you walk the walk that's really valuable to us. So Kareem, thank you so much for your time here. We appreciate it. Okay, are we done with the tallies?
Yes, we are.
Okay. Oh wait, the script. Please don't your vows. Okay. There are. Okay. Oh, you need to read it.
The tellers will read it.
You need to read this part. There are how many votes for David Martin? 13 votes for David Martin. And how many votes for Lindell? 16 votes for Lindell. So Lindell Urbina has been elected community co-chair. I thank both of the candidates and congratulations to both David and Lindell.
Lindell, you want to sit here now? I'm happy to read.
You can
the term doesn't start until September 1st, so relax.
All right, thank you all for participating in that process. It's always good for people to step up, and David and Lindell both, I appreciate you.
If I can make a comment. I'm going off script, so Jan will probably be freaked out right now. But he asked me to contact all of the folks who had gotten nominated, and there was actually a bigger group, 5 nominees, and some people said, I'm happy with what I'm doing, or not in, everybody was interested, but I think reflective of the leadership of the council, some people said, I'm better what I'm doing, co-chairing this particular committee. I want to see this through. I actually got to speak to both David and Lindell. One thing that was wonderful about speaking with both of them was that they both were very clear that, whatever happened, they were going to continue to provide leadership within the council and to support whoever was the co-chair. They both said literally the same thing in very different conversations at different times of the day, and I think that that's just a testament to the leadership, and really looking forward to seeing both of you continue to make contributions, and the rest of the council that remains to support all of you. And I told Lindell and David that I would always be a resource for you, mainly about what not to do. I'm kidding, Jesus, that was a joke. No, that community co-chair is an interesting position because it's really as much as you are willing to put into it with the support of this phenomenal planning council staff that's led by Jan. So I feel very confident in the next, the continuity with the community co-chair. And Lindell, you'll have my full support. And David, in your role as a consumer leader and a leader of the council, you'll have my full support, even though I'm coming off at 5 p.m. today. Thanks.
Okay, the next item on the agenda for today is priority setting and resource allocation committee reports. We're going to vote on money. Be conscious of $110 million. That's the goal here. And Sharon will lead us through that process. Sharon?
Hi, everybody. So I'd like you to, we're going to start with the fiscal 2013 carryover plan. It's a white piece of paper. And it talks about the total unobligated balance at the close of fiscal year 2013 being $621,408, representing a total underspending of less than 1%, 0.9% of Part A formula funding and 0.6% of MAI funding. So yes, I think that we all do deserve a round of applause. That's a remarkable delivery of service, administrative prowess of DOH and PHS, and really all of the providers getting the services out into the community. So you will recall, and the PSRA approved the carryover plan that you see here. It includes monies towards ADAP, and the housing and medical transportation are in Tri-County, and then ADAP plus dollars through MAI. The grantee also reported that they expect approximately $70,000 in additional funds because those funds will have been freed up due to a NIMH grant, National Institutes of Mental Health grant. So this additional $70,000 that you do not see here, should it become available, it will be it would go towards carryover towards ADAP. And so I'd like to open the floor for any questions on this, and absent any questions, on behalf of the PSRA, I would want to put forth the motion to adopt the fiscal 2013 carryover plan as presented, including the flexibility to add approximately $70,000 to ADAP should those funds become available. Second? I got a second, Jan. Thank you. Okay, any questions? Good. Co-chair, you want to take the...
There was, I missed it, but there was a first motion and then Julie just seconded it. All right, so any other discussion? All right, let's put it to a vote. All in favor of adopting the carryover plan, FY 2013 carryover plan as presented, raise your hands. Thank you. All opposed? Motion carries unanimously. Thank you, Sharon.
Okay. So now I would like you, there's two very large colorful pieces of paper. One says fiscal year 2014-15 PSRA ranking tool approved by the Executive Committee on 7/24. And it has categories: payer of last resort, access to care or maintenance and care, consumer priorities, specific gaps. Does everybody see that in your packets? Not to be confused with the base spending plan. We're going to do that afterwards. I want to do this first. Okay. So the PSRA each year reviews the service category and does analysis on external changes in the environment, hears from the various committees. DOH and PHS support us with data, and then we do a ranking of each service category. Now, so that before we did this, though, the IOC came to us with their revised mental health service category that we all voted on and approved. Well, within that recommendation was there had been a subset of mental health service provider agencies that were not licensed mental health providers, and specifically providing mental health services within community-based syringe exchange programs. And there was a recommendation to move those contracts and the funds associated with those contracts out of the mental health service category and into the family and supportive counseling and family stabilization category. The rationale was that it was individual counseling and group counseling, but not necessarily by a licensed clinician. The provider itself was not a licensed entity, and we felt that the services, we agreed with IOC that those services fit better under the supportive counseling definition of services. So IOC recommended the move, PSRA approved the move, and recommended it to the EC, who approved the move. So what we did was we took that dollar amount of formerly mental health programs totaling $812,733, moved those resources and contracts out of mental health and into supportive counseling and family stabilization. So then, given that information and that change in that category, we also heard from John Rojas about a $5 million cut to HOPWA. And we also, as you know, did an extensive analysis of the home and community-based health services category that was also presented to PSRA through IOC. So the rankings changed modestly for those three categories. The access to care, maintenance and care ranking for housing services went up. The payer of last resort for supportive counseling and family stabilization services went up, and home and community-based health services payer of last resort went up because of our understanding that the Bryan White resources are only triggered when there is no other Medicaid or Medicare payer of the home care or home delivered service. So given those changes in the rankings, the impact is that housing is now ranked number 3, as you can see in your chart, and that home and community-based services moved up from the 14th category to the 11th ranked category. And just to remind you that these rankings really are used to guide the Planning Council in the implementation of a cut should that occur in the funding that we get the award next year. Are there any? Or an increase, too, yes. So we don't need to adopt this, or we do need to adopt this? We do, okay.
Actually, there are 2 things we need to adopt. One is the reclassification of the mental health services and syringe exchange programs. And I just want to point out on your base spending plan, which is the other sheet that's the same size, the other spreadsheet, is the ranking tool. You'll see in column I, rows 21 and 22, or 22 and 23, I'm sorry. You see 812,000 taken out of mental health and 733, and then the same amount put into supportive counseling. So it doesn't change the overall amount, it just shifts from one category to another, this set of services that's provided, as Sharon said, in syringe exchange programs.
Just one other thing, you may have mentioned it, Sharon, but it does change it from core to non-core category, correct? As it's listed? So mental health services is core and supportive counseling and family stabilization services are non-core. Right? Just confirming.
Correct.
Okay.
Alan?
Since David brought it up, on the ranking tool, when you compare it to the executive committee, the spending plan, number 7, integrated harm reduction, the title is different from what the planning tool is calling it, so there should be some consistency in the names of them.
I think what happened, Alan, is that the integrated was the top line, it just the row height, yeah. Okay, so what Alan is saying is that on the ranking tool, line number 18 should read integrated harm reduction, recovery readiness, relapse prevention. Okay. So on behalf of the PSRA committee, I'd like to move that we approve the movement of $812,733 out of mental health and into supportive counseling and family stabilization.
Yeah, this is a Robert Rules of Order technical thing. So you presented the motion, doesn't need to be seconded. You're presenting the motion on behalf of the committee, so you can move to discussion and then to a vote.
I'd like to move to discussion.
Is there any discussion?
Randall?
I'm a little confused. Did we approve the change of the rankings yet? Or are we doing two things at the same time?
We're actually doing two things separately.
I know, but you're doing both of them at the same time. You did the rankings, we didn't vote on it, then you moved over to the other one with the money, so I'm trying to figure out which one you're doing. Are we doing the ranking first, or are we doing the change of the money first?
Okay, Randall, I'm going to explain it to you.
First.
Yes.
You just made the motion to do the other one first. So that's why I'm a little confused.
I apologize for creating any confusion. My intent is for us to do the rankings. However, before we vote on the rankings, the movement of the programs out of mental health and into supportive counseling impacted the thinking of the PSRA in our final ranking of all of the categories. So that's why I thought it would be good to first approve that move, because that move impacted the ranking. And
that's why I asked my question. I was a little, because I thought we were going to do the ranking first and then do this afterwards. So now I understand.
Is this okay?
You clarified my question.
Okay. So.
Any further discussion? Thank you, Randall, for one question is probably 5 questions in the room. People probably thought or were mixed up the same way. Any further discussion? All in favor? Opposed? All right, Sharon.
Okay, so now I would like to propose that we, on behalf of the PSRA committee, I am moving that we approve the rankings as ranked by the committee. And since I am proposing it on behalf of the committee, I'd like to move to discussion.
Is there further discussion? So now we're voting on the ranking. Daphne?
Yeah, I have a question of clarity. Sharon, so the ranking has to do with if we receive a cut or an increase. That means number 1 would get, is that the first one that would be cut, or the first one would get an increase, or is that the last one? How does that work?
Okay, so what this does for us is it creates a methodology by which we apply a cut or an increase to all of the categories, and it creates a proportionate share of that increase or decrease in resource. So if we got zero money, nothing would change. If we got an extra $5 million, then we would use these ranked percentages. They are weighted percentages in priority from top to bottom, starting with ADAP and ending with EIS. And so EIS would get the least amount of the new money and ADAP would get the most amount of the new money, because these rankings are in top priority order, and they work their way down. So it's a methodology then in the early, hopefully it'll be late winter if HRSA ever gave us our award on time, and then we would use this to implement the amount of the award across all of the categories. Does that make sense?
Yes, but there's a formula already that you've worked out and all of that, and one is certain percent, two is another percent,
exactly.
Three is another percent. Okay, you don't have to go through all the percentages. I don't want to take you through there. But I just want to know the concept.
It's a formula built into the spending plan, and when we get to
okay, so I don't need to know the concept right now until we get there.
Okay, when we get to the spending plan, you'll see how it's applied. Okay. Because we request an increase in the spending plan.
Okay, thanks.
But just to
But you can see that the score, the top, the ADAP score is 8, that's the highest, and the lowest score is 4.25, and that gets factored into the proportionate share.
Lisa?
Sorry, I may have missed this. Could you just explain the shift, the housing services rankage, the change in how it was ranked this year versus next year?
The main change that happened in the ranking for housing services is that the middle category, access to care and maintenance and care, had previously been, in years past, it was ranked as a 5. And we saw numerous studies that have come out that have linked the effectiveness of housing to connecting people to medical care, sustaining them in care, and contributing to positive health outcomes, including viral load suppression. And so that is the essence of what access to care, maintenance, and care means, and we felt that there was quantifiable data that justified increasing that ranking from 5 to 8, and that's what we did.
Yeah, specifically there was data from HOPWA that showed that 93% of clients in permanent housing had achieved viral suppression, and it was the service with the most significant and greatest, impact on achieving viral suppression. So
we were, yeah.
Any further discussion? All right, the motion is on the floor to accept the rankings as has been presented by the Priority Setting Committee. All in favor? Opposed? Thank you, Sharon.
Thank you, Jan. Okay. So now the spending plan, the money. So that's the other large piece of paper that says fiscal year 2015 base spending plan for application approved by the Executive Committee. Okay. So as I had said earlier, we did receive a presentation from John Rojas telling us about despite our HOPWA programs showing incredible evidence of effectiveness of housing and positive health outcomes, the federal government, in its inimitable wisdom, not for the minutes, decided to cut the New York HOPWA housing programs, and which will result in it's a $5 million cut, and in addition to making it a $5 million cut, they added New Jersey jurisdictions to the portfolio, so that the actual impact of the cut in New York City is going to be closer to $6.5 million. Given that and the impending loss of both permanent and supportive transitional housing units, PSRA recommended to include in our spending plan request an additional $3 million, a targeted increase, $3 million to housing in response to the HOPWA cuts. Overall, PSRA recommended an across-the-board weighted increase of 8%. That 8%, so we have, just for simple math, $100 million. 8% of $100 million is $8 million. So $3 million of that $8 million is recommended to go into housing. The remaining $5 million would be distributed proportionately via the ranking that we just approved. And this is a similar amount to the amount that we requested in the 2014 application, and our rationale for asking for an 8% increase in award is in response to the very significant, I believe it was I know it was $17 million in cuts that we took 2 years ago. Last year we requested about an 8% increase, and that did not come close to meeting the needs of the services that we lost as a community. So we felt that it made sense to request some, what did you say? Yeah, to put the money back into the service delivery system. So that's the rationale behind the 8% request 2 years in a row, with $3 million of that 8% being a targeted increase to housing as a result of the loss of housing units. The Public Health Solutions then provided the Executive Committee with information about some categories, specifically mental health and integrated harm reduction, recovery, readiness, and relapse prevention. PHS's estimation was that those two categories would not be able to fully absorb an increase based on their 3 prior years of spending. And so it was recommended that those two categories be excluded from the across the board increases. And if we were to ask for the full 8%, the added amounts would bring the base award up from $94 million to $101 million and $625. And then when combined with MAI, the total request will be over $111 million. I know it's a lot of information, so
I would just add, there's yet another spreadsheet, which is your MAI plan, which is on the legal size sheet. And we actually have, we have to request 2 plans. We could do it all as one together, but we're asking, MAI is strictly a formula. So we really don't have any say in how much we get. And last year, for the current year, the MAI award was actually increased enough that it restored the cut from last year, and a little more actually. So for PSRA is putting forward a spending plan for MAI that's just the carrying cost from this year, so the exact same amount for this year going into next year. So all of the increase that's in the request for the application is in base. And you can see on the base plan, the very large plan, in columns M and N, you can see the amount and in dollar amount and the percentage increases to every category that's in will go into the application. So, yeah. Saul, you have a question?
I'm new, and this is the second time I've been when you're reviewing this. And because I'm sitting next to her, I'm able to, I was reading and it made sense reading this. Whenever you speak about finances, and you hear numbers and abbreviations, you just go blank. I think, I don't know, you done presidential for the for others, but I think this should have been, because finance is a little bit more complicated. But like I said, I was reading behind her and I said, oh, that makes sense now. Oh, okay, that's wonderful. But it would have been better for those who are, as me, new or not as knowledgeable with the process, a written document to go along and match.
Totally doable. Totally doable.
Because,
thank you.
Wonderful, very well spoken, but at the end you go, okay.
Right, it's very easy for us to share the speaker's notes and highlight all what's new in these Excel spreadsheets.
These are my talking points so that I get it right, so I'm happy to share that. Yes.
Thank you.
I also do want to point out that I think if we will absolutely field other questions, but the MAI spending plan is really to maintain the carrying costs, and then there's a smaller sheet for the Tri-County plan. I don't know if we're going to do that separately, but Tri-County also requested an increase, and their requested increase amount is reflected on the big sheet of paper, so that if you look at the top where it says what is the base award and that the change would be $7.5 million, that you can also 3 lines down on line 7, Tri-County's base award had been 4.7, and with the additional 354, it brings them up to 5.1. And that 5.1 is also what you see in the total budget on the Tri-County. So I just wanted you to know the numbers tie, and the Tri-County award is connected to the base award to New York.
Dr. Lehane, you want to comment on that?
No, Sharon has it down. The Tri-County award is based on a percentage of the total award. So our budget must add up to 4.7% of the total award that comes into the EMA. Given those numbers, we then requested additional funds in the amount of $315,000 to go into housing, which parallels the thinking that the PSRA and the executive committee had discussed, and we were a part of that. And we had already added $49,000 to medical transportation for Tri-County region, and that's reflected in the budget on the small piece of paper, which is included in the overall budget.
Thank you.
Hey, quick question. Bettina's gone, so Gucci, it's you. Just can you talk a little bit more about the mental health and harm reduction categories not being able to absorb additional funds, what that was due to? Just top line.
I mean, it's just, it's strictly performance. The programs in those categories, their performance over the last 3 years, and their capacity to accept any more funding. In 2014, we had some additional money in the award, so we, even at that point, added a cost of living increases to those categories, and we're basically maxed out in those 2 categories as a point to actually expand them any further. The other thing is when we submit the application, we have to demonstrate a need, and really there isn't any more need in those 2 categories, and that's why the recommendation was made to exclude those 2 categories from the proportionate increase.
I don't know about need, maybe it's eligibility or wrong providers or wrong part of the city, but I get it. So, okay, just so everyone's clear, so those 2 particular categories that Sharon articulated already and that Gucci explained, whatever type of increase we get, no matter what, those 2 will not receive an increase. It's a great scenario if we get an increase. You know, more of our planning is on the cut scenario, but just so that it's clear for next year, if that does, if we do get lucky and get that increase, that no surprises there.
I did just want to say we're going to be getting the finance report, but the finance report does do a 2-year comparison of unexpended, the percent of unexpended funds from year 22 and year 23. And in mental health, it was over 6% for both years. For the harm reduction, it was 0.18% in the current year and just under 6% in year 22. I don't know if you were looking back to years 20 and 21 and that's where it was, if it was at the same level of 5 or 6% in unexpended.
Right, I mean the mental health category, that was 6% unspent in those two categories. It was actually even greater in the prior year. And with the little overage that you saw in the harm reduction, we actually increased that category this year through the increase in the award. So with the increase that that category received in this year, we are at capacity within the harm reduction category. Because you're looking at the 2013 year, we added money to that category in 2014. Yeah.
All right, Sharon.
Okay. So are there other, did I move the?
No, you haven't.
Spending plan? Okay. So on behalf of the PSRA committee, I'd like to move that we approve the 2015 base spending plan for the application as reflected in the big colorful piece of paper, and that we also approve the MAI spending plan and the Tri-County spending plan as one full package.
So the spending, okay, is there further discussion? So we are instructing the grantee to submit a proposed spending plan in the next grant application in the amount of $111 million, $447,355. That's what you're voting on today. All in favor?
I don't see the 111, but okay.
Opposed? Thank you, Sharon.
And I just want to reiterate that that includes the targeted $3 million increase to housing and the across-the-board increases totaling 8%. Thank you, everybody.
Thank you, Sharon. All right, now we'll move on to the Finance Committee report. Daniel's not here. David, you want to fill us in?
Sure. So Daniel has a new job and couldn't be here, so I'm going to report instead. Finance Committee met last week to review the closeout reports. The Finance Committee is tasked with fulfilling the legislative requirement that the council assess the administrative mechanism, which means that we oversee how well the grantee and the master contractor, DOH, and Public Health Solutions is doing spending the award. First we looked at the Planning Council budget, which is the first spreadsheet. It's just black and white. And it says at the top, DOHMH, Bureau of HIV, Planning Council budget year 23. The bottom line is, if you look on the back side, all the way down at the end on the right, that 99% was spent. There were a number of minor budget modifications, both in personnel and OTPS lines, but basically we spent what we thought we would spend, and that's pretty much all there is to report on that. So the next spreadsheet, which is says at the top, Public Health Solutions, HIV Care Services, year 23, fourth quarter closeout, Ryan White, Part A base. So overall spending was at record levels this year. In the base award, the majority, there was only $615,733 unspent. If you look on the back, in column X, column Y, all the way in the, let's see, row 59, you'll see that number. That represents 0.65% of our grant. Last year it was 2.2%, and that was a record. So it's pretty amazing in the budget of about $94 million of base program dollars that they spent 99.35%. Okay. In the base award, the majority of the underspending was in quality management and some in New York City administration. That was due to staff vacancies. DOH wasn't able to post for vacant positions until the award was received. Most of the remainder of the grant, of the underspending, was in Tri-County. So for actual program dollars in New York City, it was basically almost all spent. The master contractor reported on the takedowns and enhancements. The first round was done in January, which is later than usual because of our late award. Then more were done after closeout. $3.8 million were reprogrammed according to our plan, so overperforming contracts were enhanced, and one-time takedowns were done for underperforming contracts. Excuse me. Just a note, enhancements had to be capped because there just wasn't sufficient funds to enhance every overperforming contract, and that's just because we spent so much of the grant. The Tri-County region also had a record year for spending with only $51,880, about 2% unspent. So kudos to the Westchester Department of Health. In the MAI award, which is the next spreadsheet, you'll see in column W, row 28, of all the MAI funds, $5,669, or 0.06% unspent. All-time record. Of that 5,669, 5,665 is in Tri-County. That means in the city, all of $4 was unspent. So it's miraculous.
Daphne?
I have a question about the unspent, since we did so well, do we still get the full award? I mean, is there like a policy where, since we're so, like at 0.69%, and do they still give us the full award?
Yeah, well, the award is given, it's supposed to be given at the beginning of the year. It's given towards the beginning of the year. This year we got it in June. And this is actually year 23, so 2013. So it's the year that began March 1st, 2013, and ended February 28th, 2014. So it's last year, not the year we're in. So the award was given towards the beginning of the year, and this reports how they spent it by the end of the year.
My question is, are we still going to get the 733? That's my question.
Oh, yeah. Well,
that's all I want to know. Are we still going to get that? When we get it? I
see what you mean. This gets applied to the carryover for the next year.
Okay, but we're still going to get it.
Well, yeah. I mean, supposedly we have to submit a plan to HRSA, which we do every year.
Okay.
But this would be the year 2014 carryover into year 2015. So at this time next year, we'll come back with a plan for how we're going to spend this $615,000.
But we can still get it.
Yes.
Okay.
Exactly.
That $615,000 or $621,000 is actually going to come in the 2014 year. The year that we're in now.
That's right. Yeah, exactly. Yeah, we haven't closed out.
But if you look at your own bank account, I mean, it doesn't matter if it's this year, next year.
It's going to come into this.
Is it going to be a direct deposit?
So, anyway, yes, this is the money that's in the carryover plan that you just passed.
Okay.
Exactly. All right. So, the last spreadsheet says it's assessment of the administrative mechanism. This is basically just a summation of the Finance Committee's work over the course of the year. It's just basically a checklist so that we can say in the application we fulfilled the requirement to assess the administrative mechanism. We have 4 basic measures. One is executed contracts and renewals. The other is procurement, then subcontractor payments and spending. And the findings, which is the last column, is basically the summary of what the Finance Committee was reported over the course of the year, all the reports that Dan gave after each quarter, and this report. So the two that are in red are different from last year. Executed contracts renewals for 2013. Basically, there was a late award, as we know, and then we got a huge cut. But DOH and Public Health Solutions created a plan to implement the cuts that we approved in our spending plan, and contracts were adjusted, renegotiated, and executed on a timely basis. Uncommitted funds from contract negotiations were reprogrammed based on our reprogramming plan. Then under procurement, the previous year, 2012, there were no RFPs, so this was basically blank. Last year, there was the housing RFP. The RFP was released on July 24th, 2013. Contracts were announced in that December. 14 awards were made, 1 in short-term rental assistance, 8 for short-term housing services, and 5 in housing placement assistance. The awards were posted on the Public Health Solutions website, and then there were negotiations, and the contracts executed on a timely basis, and then the grantee reported that out to us in December in the full Planning Council meeting in the grantee report. For the other two measures, the other two criteria, it's basically the same as last year. Subcontractors are paid in a timely manner within 60 days of receipt of a complete and accurate expenditure report or invoice. And as I just reported, the expenditures by service category, which were reported quarterly to the Finance Committee, the Executive Committee, the full Council, and spending rates were at record high rates. So basically, we just need to approve this spreadsheet. So someone wants to, is there any discussion, any questions? Anyone want to make a motion?
All right, staff member cannot make a motion.
Does anybody want to?
So is there a member of the council that would like to move this acceptance of the...
I move that we accept the...
Assessment of the administrative.
I can't hear what...
Assessment of the administrative mechanism.
I'd like to move that we accept the assessment of the...
Administrative
mechanism.
All right, since it's coming out of a committee, does not need to be seconded. Is there further discussion?
Is it?
Oh, I'm being advised otherwise. So it does need a second. Alan?
Second.
Alan seconds. Is there further discussion? All right, all in favor of accepting the administrative mechanism review as presented? Opposed? Okay, great. All right, we're done with voting. Thank you all very much. We've made some real significant shifts in ranking, in dollars, in addressing what we believe to be unmet needs in housing and other areas. This is all a culmination of months and months of work, many, many meetings, and lots of phone calls, and many trees. But it's all for the good of people living with HIV and AIDS. Adrian, would you like to give us an update on policy topics?
Unless everyone wants to keep talking about numbers for just a little longer. No? All right. I promise not one number in this whole presentation, because I feel the same way. I stopped understanding math in the 8th grade, so I have to struggle to keep up. But it's good that this is at the end. We'll just kind of touch base on a couple of HIV law and policy issues we thought you'd be interested in. The policy committee put together a couple of slides. The first update we wanted to share was, as was mentioned earlier this afternoon, the International AIDS Conference is just about wrapped up now. I think last week was when most of the events were. It was in Melbourne, Australia, as you all know. And Jen and Nina did a really great job in highlighting a couple of the presentations and sessions that took place last week. There's a couple they listed involving mental illness, some gay men's health issues, one on viral load suppression among substance users here in New York State, HIV testing within the transgender community, and a handful of others that they wanted to highlight. And I just want to direct you to www.aids2014.org. That's the website of the conference, and there you can find all of the materials related to these presentations and sessions and workshops, as well as it must be hundreds of others that were featured during the week. So I encourage you to visit that website. I actually don't know where it is next time. There. Does anyone? Where? In where? Oh, cool. That's exciting. Slightly closer.
Been there.
Well, in 2 years' time, we'll present some of that to you as well. So the next thing we wanted to touch on are some of the quote wrinkles that have appeared in terms of the ACA, the Affordable Care Act rollout, particularly for people with HIV. So we presented this at the last policy and last executive committee meeting, but just to share with everyone, to let you know, in Florida, there's some really great work being done by the AIDS Institute down there to determine how the plans are rolling out and affecting and benefiting people with HIV in Florida. And after doing a very comprehensive review of all the different health plans that were offered to Floridians living with HIV, they discovered that 4 silver-level qualified health plans in Florida offered by the Affordable Care Act are making HIV drugs unaffordable to people living with HIV. So you can see the HIV meds were all listed in Tier 5, which meant that the deductibles were upwards of $3,000 for treatment. And one presumption is that this is happening so that they can dissuade people with HIV from signing up for these particular plans. So in response to that finding, the AIDS Institute and the other organization which worked with it to conduct this survey, they filed an administrative complaint with the Division of Civil Rights with the Department of Justice. And they basically are claiming that pricing dissuades people with HIV from joining these plans, which constitutes illegal discrimination on the basis of their disability.
Next slide, David.
Which is HIV. So they're requesting some financial penalties and decertification of plans. So even though this is sort of limited in this case to what's happening in Florida, this sets really good precedent, because if this, as we continue to learn more about how the ACA is affecting people with HIV, more of these studies will be done in more states, and this sets a sort of model for what we can do to fight the discrimination that some of these plans may be exhibiting. So it's important to track, and we'll be doing so over the summer. The second thing we wanted to mention was, as many of you probably know, during Pride last month, Governor Cuomo announced a strategy for reducing new HIV infections here in New York and lowering the number of New Yorkers living with HIV. And New York is the first state to publicly announce a strategy for ending HIV. And he outlined 3 different prongs for how we are going to accomplish this. The first being to focus on locating undiagnosed people and connect them to care. The second, to maintain them in care and on medication to enhance viral suppression, preserve health, and stop transmission. And the third, and the most important in many ways, is the commitment to making PrEP available for high-risk people who are not living with HIV. So this is a big deal. New York is now the first state to sort of publicly announce its commitment to ending AIDS as a jurisdiction. So the announcement also included a significant amount of discussion on the cost effectiveness of such a plan. So in the announcement, they outlined that every prevented infection avoids close to $400,000 in medical costs over a life. And by 2020, the plan, as outlined, will conserve $317 million for New York State and avert over 3,400 new infections. So also in your packets, there's a New York State Department of Health letter on Department of Health letterhead, and this is from Dan O'Connell, the director of the AIDS Institute, and he outlines with quite a bit more specificity exactly how the AIDS Institute is going to work to get some of this work done. Obviously, more information will come out in the next couple of months, and we'll be able to disseminate that to you. I guess next time we meet, there should be a lot more out there for us to report back. And I think at the executive committee, we also discussed how, specific things that the AIDS Institute is doing, and possible ways that they could partner with the city Department of Health on making sure this rolls out efficiently and effectively. So that's really exciting. I mean, this is unprecedented, and I think it's a really exciting time to see what this partnership will produce. Sort of related to that, we also included a couple slides on the WHO recommendations regarding PrEP. This has been all over the news. You know, it was a cover story on New York Magazine, and lots of major newspapers, including the New York Times, have covered it. Basically, the WHO recommends that after a series of studies, they recommended that where uninfected members of serodiscordant couples become infected, oral PrEP on a daily basis can be contemplated as a potential additional step to protect the HIV-negative individual, and also in locations where HIV spreads between men and transgender women who have sex with men, and where supplementary modes of prevention are wanted, daily oral PrEP can be contemplated as a potential additional step. This is also a big deal. This is a major health organization that is setting forth really strong recommendations regarding the use of PrEP, which really is a relatively new concept. It might not seem like it because it's sort of what we do every day, I think, but for, I think on a larger scale, this shows a new direction for public health in a way that hasn't, in an unprecedented way. So that's also big news. And the last thing we wanted to touch on was some updates on HIV criminalization. If you remember a couple months ago, one of our updates had been that the CDC and the Department of Justice had issued a report calling for states to conduct an assessment of HIV-specific laws and what effect they had. Well, as a follow-up to that, they took it a step further. The U.S. Department of Justice just issued a best practices guide to reform HIV-specific criminal laws to align with scientifically supported factors. So essentially, they are calling on they're actually offering technical assistance to states to conduct these assessments to determine whether or not their HIV-specific laws and policies are actually helping, and if they're in line with the current knowledge of HIV relative risk and routes of transmission. Just to remind you, almost 36 states and territories here have HIV-specific laws that target someone with HIV for a number of offenses, and not only that, but being HIV positive could be a sentence enhancement for a number of crimes. So this is a big deal, again, because the Department of Justice and the CDC are now taking increasingly strong positions against HIV-specific crimes that don't reflect the current medical landscape. And also at the International AIDS Conference, the U.S. ambassador to Australia, or no, it was the Australian, we talked about this last, I mean, somebody that's, it was a rather brave position for them to take, supporting the end of the criminal law to target people with HIV. So there's a lot happening on this level, both here domestically and across the world. So that's something to keep an eye on, and we will continue to do that. And that's it. I just want to reiterate the importance of those Office of National AIDS Policy listening sessions. It's really exciting that they're coming here, and I think many of the sponsoring organizations have representatives around this table, so you know all about it. But I don't remember if Nina and Jen, if we had resolved to put something together on behalf of the council through the policy committee. So we'll be working on something that aligns with our mission and our work, just to make sure that they keep Ryan White, that we keep Ryan White on their radar, and make sure that they incorporate us into their decision-making processes.
Thank you, Adrian.
No problem. Thank you.
Wow, thanks again, Adrian. You know, one of the things we encourage, and we've got a new new recruits coming in for the new planning council in October is for people to get engaged in the policy committee work. So, it's exciting going into next year. There's a whole bunch of, wish we could deep dive into some of the stuff that came up, but I'm sure with our new assistant commissioner that's joining us, that Graham is going to talk a little bit about in his grantee report in a moment, we'll have some of those opportunities. So Graham, you're up with the grantee report.
All right, thank you. First news is we have received the application guidance for 2015. We're in the middle of putting together the application. We have draft 1 together, and that'll be reviewed over the next week. The Planning Council will have an opportunity to take a look at the grant at draft 3 at the end of August. David Klotz will send out a time for people if they want to come in and review the application, give comments, which is always a helpful piece of feedback for us to receive.
It's going to be August 19th and 20th. I'll send out notices.
Great. As we just heard, we have a new Assistant Commissioner of HIV/AIDS Prevention and Control coming to the Bureau in mid-September, Dimitri Daskalakis, who received his undergraduate degree at Columbia College, his medical degree at NYU School of Medicine, his master's degree in public health from the Harvard School of Public Health. He trained in internal medicine at Beth Israel and had a fellowship in infectious diseases at Partner Healthcare, also in Boston. After completing his training and moving to New York City in 2005, he established himself as a leader, innovator, and spokesperson for people living with HIV and gay and bisexual men. He pioneered programs that brought HIV testing, vaccination, and other vital care into bars, clubs, and bathhouses to reach men at risk of HIV and other infectious diseases. In 2013, he played a role in helping stop an outbreak of meningococcal meningitis among men who have sex with men, running community events that vaccinated over 2,400 men, an estimated 10% of all men vaccinated in New York City as part of the outbreak response. In July 2013, he served as an associate professor and medical director of the HIV program at Mount Sinai. In his new role, he'll be responsible for accelerating declines in HIV infections, eliminating disparities in HIV mortality through adoption of new tools, intensified community outreach, and strengthening of existing programs. We're very excited to have him come on board. I met with him last week, and I shared that I really would like him to become engaged in the work of the Planning Council, to really be in a position of leadership. So we hope that he'll be able to come here soon in the fall and share his vision for the Bureau and the city. We have attached a New York Times article for your review, if you'd like to take a look at it, highlighting his work. The other announcement is John Rojas, the current interim Assistant Commissioner and Director of HIV Administration and Housing. He'll be taking a new position as Assistant Commissioner for Management in the Division of Disease Control. So many congratulations to John Rojas. The unobligated balance, I'm not going to go through that because that's basically what was shared in the carryover plan that we approved earlier. And then I would like to just extend an invitation for people if they are interested. We have a monthly interagency meeting where we review quality indicators for service categories. And if you are interested in coming and reviewing these service category indicators that are based on eShare data developed in collaboration with providers, I invite you to come and just contact me and I'll add you to the invitation. And that's everything. Thank you.
Thank you, Julie. Tri-County?
There's nothing new to add from Tri-County at this time. Thank you.
Thanks. So before we do see if there's any public comment, can everyone pull out the Planning Council meeting survey? And please make sure to take a few moments to complete that and get that back to Planning Council staff. Are there any public comments? Okay. Yes, David.
There's a discrepancy with the time for the White House meeting. On the card, it says 1 to 4, and on the sheet in our packet, it says 1:30 to 4:30.
Yes, there was a change that was made, so it's going to start at 1:30, but we will be letting people in, and we have refreshments at the 1 o'clock start.
Thank you.
Yeah, you just want to get us there early. That's what it is, right?
Yeah.
The little bait and switch. Excellent. Stephanie, quick question on this. These are being done throughout different regions in the United States, across states. So this is the one, is it specifically for New York, or is it an East Coast?
Specifically for New York.
It's great. Do you know where the other ones are, or some of the others?
I can forward you a list.
Yeah, but they're doing South and West Coast, and so,
Most
yeah.
of them have already happened.
That's great. So it really is important. And he's new. He was appointed this past year to the White House. So a great opportunity, folks. So with that, if I can... Oh, Billy, sorry.
I just wanted to say one thing. To the outgoing Planning Council members, I'd like to express my gratitude to each and every one of you for the service you have rendered in the past years. In this final relationship, the Council has cooperated well to serve the people of the Ryan White Fund Services. You have assured the business of this council shall go forward. So now your official relationship with this council has ended. In feelings of gratitude, we have been able to do so much together. So simply I say to you, thank you for caring for those less fortunate and underserved. Good luck and be well.
Beautiful way to end the meeting. Thank you, Billy. And I'm going to miss you guys. Have fun next year. Enjoy the rest of the summer. I'm going back to my twins. So, motion to adjourn. I got a picture. I should have shown the video today. I'll send a little video link around. It's on Facebook. It's been making the rounds.
You can make a PowerPoint, but only 10 slides with pictures.
It's a 1-minute video. How's that? Thank you, guys. All right.
Thank you, everybody. Have a good summer.
Who's picking up the surveys? Okay.